Hello, friends. So we're live on Facebook, and today we have wonderful Dr. Rahul Sharma, and he'll be sharing with us on behalf of Global Summits Podinar. We're seeing it live, and he'll be talking to us about prosthetic solutions for the distal saddle ridges. We were talking before, and we had a very lovely conversation. So we thank you for joining us today, for taking time from your Sunday, from your families, and we honor you for wanting to learn something more about this topic. It's always important in dentistry to keep up with any type of new learning, new opinions. So I'm very excited to present to you Dr. Rahul Sharma, who is a graduate from Rajiv Gandhi University, but his experience doesn't stop there. He is a well-accomplished implantologist, has a master's in prosthetic dentistry, and is also the author of two books that you can find on Amazon. We'll leave the links during the course of our webinar today. And one of the books is on ceramics in dentistry, and the other one is also a very important topic in dentistry, which is dental implants and biomaterials. So I'd like to have Dr. Rahul tell us a little bit more about himself, where his practice currently is, and so I'll leave the microphone to you right now.
Thanks. I'll take the charge now. First of all, good morning, good afternoon, and good evening to the viewers around the globe. And I want to express my gratitude to the team of Global Summit to provide me this platform where I can share my knowledge and, of course, gain some experience from the viewers and from the host as well. So apart from my brief introduction, I would like to add some things. Dr. told I did my master's in prosthetic dentistry. Then I hailed to Saudi Arabia. I was working there as a specialist for 3 years. And currently I am working in Bahrain from past 5 years. And I am specialist prosthodontist and implantologist here. My practice is purely focused on rehabilitation of the missing dentition and with kind of removable and the fixed prosthesis both. So this is a brief about me, and that's all. I'm ready to share my screen if introduction part is over.
Yeah, it's fine because we were having some interesting exchange before about how important it is to reach the global population with solutions. So we're definitely eager to learn from you. So please share your screen and I'll disappear. I'll come back later, and happy learning to everyone connected right now. Thank you.
Try to share my screen. I hope it is visible.
Yes, it's fine. Perfectly.
So my topic of discussion today is prosthetic options for terminal ridges. That's a clinical approach. The reason why I selected this topic, as we all are aware of the Kennedy's class 1 situation and Kennedy's class 2 situation, these two situations are really like a nightmare for every clinician who really have to struggle to rehabilitate such conditions, whether it is means of retention, mastication, or aesthetics, or of course, economics. It is very tough sometimes to put your efforts and fulfill your or finish your treatment, and at the end not achieving the up to the mark results, and the patient is not satisfied sometimes. These are the common issues what we face while rehabilitating the terminal ridges, or we can say the distal extension or freestanding ridges. So let's start the show. This will be my roadmap for today's presentation. I will be talking on the prevalence or incidence of the percentage of cases of Kennedy's class 1, 2, 3, and 4. Then I will be discussing about the treatment options available for the different type of situations. And at the last, I will discuss different clinical situations or the decision making for the particular case. So this is the common question what every clinician has to face, or we are facing in everyday practice in the case of distal freestanding ridges, is how to rehabilitate that particular case. What options we have. and which option is good for this particular case. Because sometimes patient demands fixed options, which is not suitable for the particular situation. We have to motivate the patient for the removable options, or vice versa. Sometimes patient don't want removable options, or it is not possible to do the implants. So all these situations we have to face in our everyday practice. So I will be putting some light and going in depth around for the situation, how to handle the distal extension ridges. So this is me. As I told you, I'm a prosthodontist and implantologist. I hail from India, and currently I am working in this beautiful country. It's an island known as Bahrain. So after looking the prevalence of the Kennedy's classification of class 1, class 2, class 3, and class 4, this is the article published in JPD 1922. According to this, 40% of cases prevalence is Kennedy's class 1, 33% is Kennedy's class 2, 18% is Kennedy's class 3, and 9% is Kennedy's class 4. So it's a big number, 40% and 33%, Kennedy's class 1 and class 2. So total it is 73% is the situation what we have to face every day in our practice. And it is really true. We are facing these situations. We are seeing such cases in our day-to-day practice, and clinicians are facing huge troubles of to manage or to rehabilitate the distal extension situations. So before proceeding to the treatment in depth, I want to categorize the treatment options in 3 types. The first is completely removable prosthesis. The second is segmental fixed prosthesis. And the last one is the fixed prosthesis. The segmental fixed means some portion of the prosthesis will be fixed and the remaining portion will be removable. So we can say it a kind of a semi-fixed prosthesis. So first I will discuss a little about the available removable prosthesis options. As we all know, the very common option is our acrylic dentures, but many clinicians I have seen, they are considering it as a permanent solution. But no, it is not a permanent solution. It can be used for a treatment phase for a short period of time or a limited period of time because of many disadvantages, like its design. When clinician decided the design of a acrylic partial denture, it is not completely tooth bone. Majority of the cases I have seen, it is always tissue bone prosthesis or gum strippers, which can lead to the tearing of your gums and discomfortable situation to the patient. Moreover, the design, it is not a design which can bear the load for long term. It is very unstable prosthesis. It has a clasp which comes in the aesthetic zone and which will be really unpleasant for patient. Moreover, its porous nature can attract plaque accumulation as well. So for a hygiene purpose, it is not be advisable for a long-term prosthesis. The next one is flexible prosthesis. Of course, it has some advantages than the acrylic one. You can say it has almost negligible chances of fracture like what our acrylic has. Moreover, aesthetically, it is more presentable. But again, I cannot consider it as a permanent prosthesis because the force distribution in this kind of prosthesis is not uniform because it does not have any occlusal rest, no stable or firm framework it has. There is no clasp, there is no direct or indirect retention. So just to overcome the fracture resistance, we cannot just jump onto the flexible prosthesis. Of course, again, it can be used for a little longer term, or you can say the shorter, the long term duration, but of course cannot be used for a permanent solution. Moreover, such kind of prosthesis, the flexible prosthesis, they need a good amount of interarch space because the teeth attached in flexible prosthesis are mechanically locked, not chemically sealed. So if you have a limited space interarch, there are chances of separation of the tooth from the underlying base. Although it is good in the cases of microstomia or the limited mouth opening, but we cannot still consider it for the long term because it can have a detrimental effect on the abutment surrounding to it. The last one, removable, is the most acceptable one, is the cast partial. We all are aware of it. It has a strong framework, a good occlusal rests. If properly surveying is done, if proper planning is done, it is a good long-term solution for any kind of Kennedy's class 1, class 2, class 3, class 4, any situation. Of course, it has some demerits. The rotational movements can happen. But as I told you earlier, if designing is good, if proper surveying is done, it has good indirect retention that we can reduce those rotational forces towards the fulcrum. And in recent advances, there are quite modifications in a metal framework are there, like in metallurgy, there is titanium framework available, there is PEEK material available, which are good in strength, good aesthetics. So if we have to compare the three removable prostheses, I can suggest CPD, or you can say cast partial dentures, or the metal dentures are the most accepted removable prostheses. So let's move on to the segmental fixed prosthesis. As I told you earlier, in segmental, it means a portion of your prosthesis is cemented or fixed with the abutment, and the remainder of the portion, which is covering the distal extension, will be removable one. So it is two-piece or two-part of prosthesis. I'll share some photographs. You can have a look here. We all are aware of precision attachments. This is a kind of segmental fixed prosthesis. This cast shows the prosthesis with extension of extracoronal precision attachment. This is Rhine 83 attachment. They have ECA attachments. We have many attachments, SICA attachments. Some are extracoronal precision attachments, intracoronal precision attachments. We have studs, bars. So all these prostheses or these attachments can aid or increase the retentive portion of the removable prosthesis. The tissueward movement of the prosthesis will decrease. And moreover, if it is a situation of class 1 Kennedy's classification, I mean to say bilateral edenturism, you can connect both sides of the portions with a metal bar. It will be a single frame. So we can have the added advantage of the cross arch stabilization as well. The next option in segmental fixed prosthesis is the telescopic crowns. It is also known as double crowns. It's a kind of preventive prosthodontics, which follows the Dr. Muller-De Vance statement, which always says we should preserve which is remaining in the mouth rather than replacing which is not there or which we have lost for any reason. So this is a kind of a preventive prosthodontic approach. And in telescopic dentures, it consists of two components. One is the single, or you can say the first part. These metal copings you can see here, these are the first crowns, which is of full coverage, of course. They are cemented on the abutment teeth with the restorative material, with any restorative cement. They are cemented and completely covered. On top of it, there is another part of crown, which is a part of a RPD framework. I'll repeat again, the first portion of the crown or the first crown will be cemented on the abutment, and the second portion of the second crowns, you can say the other crowns, they are a part of a existing RPD framework. You can see in this cast. And the second crown is just sitting on the first crown without any cement. There is a friction in between. It's a frictional mechanism because of what they are getting retention from the down one, from the first part of the crowns. That's why it is known as double crowns. So first crown is cemented on the abutment, and the overlay on the overlay crowns, they are just with the help of frictional mechanism, which are a part of the existing RPD framework. They will sit on the existing crowns, and they will give retention to the remaining portion of the prosthesis. It has many advantages, like it can save the abutment from the future caries, and it will maintain the periodontal health as well. And if we talk for the force distribution, it will act on the long term of the abutments because of the full coverage of the second crowns. So overall, it is a good viable option if your abutments are periodontally sound, if they have a good crown root ratio. This is one of the viable option in certain situations. Next is implant supported RPD. It is not implant supported fixed. I'll talk in that in my later slides. This is implant supported removable partial dentures. This have been noticed with the advancement in implant dentistry. Implants are everywhere. We can place implant in any bone if the bone is sound. So in Kennedy's class 1 or class 2 situation, this is one approach. We can place implant in the distal or the terminal areas, which will convert our classification from Kennedy's class 1 or Kennedy's class 2 to Kennedy's class 3 implant bounded. Additionally, it will reduce our edentulous span also. And moreover, when we place two implants in this case as the terminal implants and make a cast framework on top of it, these locators or these ball and socket attachments give additional retention to the existing RPD. If we compare to the conventional cast partial, this will be more retentive because we have two retentive components bilaterally on the terminal space. So our classification has converted from class 1 to class 3 implant bounded. So it has many advantages, good retention, good stability, and patient can have the better function and mastication with such kind of prosthesis. Next option is fixed prosthesis. In this, we are aware of the cantilever bridges, which is not a very good option for distal extensions. Of course, we can use in anteriors, but still I don't prefer cantilevers for the posterior areas. And we have implants in fixed. There are different types of implants available nowadays because of all advancements. We have endosseous implants. We have pterygoid implants. We can take the support of zygomas as well to rehabilitate the distal ridges. And this is one more new type of thing is there. These are 3D printed implants. Suppose if we have a resorbed ridge where our anatomical constrictions are there, where we cannot enter in the sinus and cannot enter in the nerve, we can 3D print these implants. Just a minute, I have jumped 1 second. Sorry for the interruption. So as I discussed already, cantilever bridges. So endosseous implants, pterygoid implants, zygomas, and 3D printed implants. So I was discussing about the 3D implants or 3D printed implants. These are very good options for atrophic maxilla or mandible. They can do segmental implants. They can fabricate a segmental implant or a complete arch implant as well. So these are the three types of categories of prosthesis, what is available, that is removable, segmental fixed, and fixed one. Now, before doing any treatment for a terminal ridge, or we can say distal extension, we need to understand why rehabilitation of free and terminal ridges is always challenging. Why we always struggle so much during what we have to decide, what type of options we have, why it is considered so challenges, or why we are facing challenging after the completion of the treatment. The reason is that there is no distal abutment to support. So when there is no distal abutment, definitely there is no source of retention. There is no distal source of retention if we don't have distal abutment. That is the first reason. Second reason is it is a tissue and tooth supported prosthesis. So we are depending on two components, that is the abutment and the underlying tissue and bone for support. And these both components react in a different way. So if you have tissues underlying, they have different compressibility in different situations, and which is different from tooth. So what happens when we get force, the masticatory force, when it applies on the prosthesis, these both components have a seesaw mechanism. They will not react in the same manner. So there will be difference in movement between supporting abutments and mucosa. That is the reason these kind of prostheses for terminal ridges are considered little compromised, because we are depending on two components. One is tooth and one is tissue or the bone underlying. So, and both these components are different in nature and different in response. You can see here in this edentulous ridge, when there is force of 4 newtons applied to this ridge, the ridge and the mucosa will compress almost up to 500 microns, whereas the abutment will only compress up to 20 microns. So we can consider here, if any force is getting applied when we do the mastication and patient is wearing a removable prosthesis, it is not planned properly. So under this force, the response of the tissue will be different and the response of the tooth will be different. So our tissue and tooth supported prosthesis will start rocking and rotation will happen and end up in complications. That is the reason why we always say the treatment of terminal ridges is always challenging. I hope I am clear in this concept. So let's move on to the clinical hurdles for the success of the treatment. There are many hurdles which can interfere during your treatment planning or during your first session when you meet with the patient and during that time. There are total 4 hurdles which can come on our way while planning the treatment plan. The first is inadequate training of clinician. This is the main flaw. Sometimes I can say that eyes doesn't see what mind doesn't know. Eyes cannot see the thing which it's not there in the mind. So if the clinician is not trained or not sufficiently qualified with all the treatment protocols and their indications, their advantages, disadvantages, so he's not able to fulfill the patient's desire. Sometimes in our college time, we are not that much trained to do all the procedures, and we end up in practice with limited knowledge and limited area of working. And at the end of the day, who is the sufferer? That is the patient. So if any time I suggest you feel you are not trained enough to deal with that patient, or if you're not having multiple options because of any reason, you should always refer to the specialist. That is the best way to overcome this issue. The next one, the big hurdle, is again untrained technicians. As we know, any prosthetic treatment is incomplete without a good or trained technician. And this problem is very common around the globe. Sometimes something is there in our mind and we are not able to communicate with the technician because of his lack of knowledge or lack of resources. And again, end of the day, who is the sufferer? Patient. He is the sufferer. Unknowingly or knowingly, he is the sufferer. So we should always unite, or we should always get a trained technician in our team who is aware of all the protocols, all the procedures and all the steps, and who can coordinate with you and overcome this second hurdle. The third hurdle, which is again very common and very tough to deal, is patient awareness. This is really tough to explain to patients sometimes when the patient comes with, because for the patient, it is very common thing to lose the tooth. And patient will come and say, I don't have doc, I don't have missing teeth, I don't have teeth in my back region, please fix it. There is their common desire, they want to fix it. So this fix has many names in our practice. Fix means we always think of removable option, fixed options. We try to motivate the patient. No, we cannot do fix in your case. Maybe you are not sound medically, you are unfit. Maybe your ridge is not sound. Maybe the quality of bone is not good. Or sometimes patient cannot afford it, and because patient is not aware of the treatment cost. So patient awareness plays a vital role, which can interfere in our treatment modalities. And sometimes we cannot every time fulfill the patient's demand as well. Is finances. These are the 4 factors which end up in the compromised result. So let's see the factors which will help us to decide clinically what option is good for this particular case. I have categorized these decisions or these factors in the 5 pillars for this treatment. So you can say these are the 5 pillars for clinical decision for terminal ridges while rehabilitating the terminal ridges. We should always remember whenever patient arrives in our operatory, we should not jump immediately on the treatment. Like we have CPD, we have removable, we have fixed. Without examining the patient's mouth from inside, we should not jump directly on the treatment plan. As we know, we should always meet the mind of the patient before meeting the mouth of the patient. And after you meet the mouth of the patient, these are the 5 pillars what you should always consider without taking any decision. So the first one is abutments. Very crucial, very important pillar. You have to evaluate the remaining abutments, the surrounding abutments which are present close to the edentulous span. You have to look for the situation, the location of the abutment, how many abutments are available, what is the crown and root ratio of that abutment, how is the periodontal status, what is the angulation, are they tilted, are they aligned or malaligned, which, because generally if there's a missing tooth, definitely there will be drifting or physiological movement of the remaining abutments. We have to notice for the supra eruptions. So all total, we should consider a sound abutment, and depending on the abutment situation or the condition of the abutment, our treatment plan depends. So this is a very important pillar. The second one is soft tissue. Again, as I explained you earlier, we are depending on abutments and soft tissue. So how we can neglect the underlying soft tissue? We have to palpate it with your hand. You have to feel the consistency, whether it is displaceable, is it resilient, is it firm, how is the bone quality? Try to evaluate the bone both from the buccal and lingual sides. How much is the bone length, width? All these has a very important role, because if it is displaceable tissues, whenever your prosthesis is under function, it will get displaced. You will not get that stability and support from underlying compromised soft tissues. In certain situations, we have to go for a pre-prosthetic surgery. We have to make our mouth ready for the prosthesis to receive. So this is the second important pillar, that is soft tissue, which is again very crucial for determining or for your clinical decision. The third one is the residual bone. Most of this I have explained in the part 2 in soft tissue, but yes, residual bone, if you are aware of the classification of the Atwood's classification of RRR, residual ridge resorption, nicely they have explained the residual pattern of bone. So we have to evaluate the underlying bone, whether it is broad, is it knife edged, is it resorbed? Because if we have a broad ridge, it is good for prosthesis in certain way. It is good for stability, but not good for retention. If you have a resorbed mandible, if the pillars of your bone are not very sound, there will be no stability, there will be no retention. So you will end up in the compromised prosthesis. You have to plan for maybe augmentation, maybe some other options, maybe the precision supported prosthesis. So this all depends on the quality and on the volume of the residual bone. These are the 3 pillars. The fourth one is antagonistic arch. Again, very, very important and very crucial, which generally we bypass. Why this is important? Why we have to see the opposite arch if we have to rehabilitate the lower one? Because in occlusion, they come in contact, right? So we have to notice what type of dentition patient has on upper arch, whether it is a natural dentition, whether it is crowns, the porcelain ceramic crowns or zirconia crowns or Emax, whether it is a removable prosthesis, whether it is implant supported prosthesis or implant supported fixed crowns. Our occlusal scheme, our treatment plan gets interfere with that. Our occlusal scheme, we have to plan according to the opposing prosthesis. So that's why antagonistic arch is very important. Sometimes because of the lower missing, patient has supraeruption of opposing dentition. So straight away, we cannot rehabilitate that because there is very limited restorative space. So we have to plan to uplift that and create a restorative space and then proceed with the procedures. So definitely antagonistic arch plays a very important role while taking any decision for the rehabilitation of your distal free saddle ridges. And the last one is again the same, financial status. Here we don't have much role to play. It is on the patient's head. And as we know, the dental procedures are not pocket friendly. So if you have a situation when all the 4 factors are decent, they're under control, but the 5th factor, the financial situation, is not in the control. So we have to follow the patient's concern as well. And we should deliver some such kind of options. We should discuss all the protocols, all the treatment costs before starting any procedure. And we should take the patient's consent for every procedure. So these are the 5 pillars for your clinical decision. So to explain a little more in depth, I have created some scenarios considering all these 5 pillars. First, I will start with the Kennedy's class 1 classification with one scenario so that we can have a little bit of knowledge or a little bit of insight view that how we should decide the particular case. Example is Kennedy's class 1, scenario 1. These are the situations. In this case, consider the abutment is periodontally weak. Restorative space is adequate. Medical condition is favorable. Financial situation is also sound. And the residual bone is also adequate. But the main pillar, the first pillar, the periodontally weak abutments. So what happened? We cannot take the support from the abutments. If you're giving occlusal rests, if you're taking your clasp, your bracing arms, your direct retention on these weak abutments, they are going to weak further. So ultimately, we are going to lose those abutments in a short period of time. So if this situation is there, patient can afford and good bone, we should prefer implant-supported prosthesis. Whether it is fixed or removable, that depends on the clinical scenario. So this is scenario one, when we have a weak periodontal abutment. Second scenario, in this case, everything is controlled, but there is inadequate space, the supraeruption of antagonistic arch of opposing jaw. So in this picture, we can see there is limited space, or I can say there is no space for any kind of prosthesis. We cannot make even acrylic temporary partials in such situation. So first of all, the first approach, we should always plan to uplift or create a restorative space. So you can take the help of orthodontist, you can do orthodontic uplifting, or if patient is not ready, there is one harsh option is there, that is do intentional root canals and tooth preparation of more, maybe we need to do the crown lengthening and uplifting of the antagonistic arch. Then you can plan for either CPD or flexible for short duration for the treatment time, or implants, fixed or removable. But creating a restorative space is really important for such situations. The next scenario is again class 1 situation. In this, the patient is medically compromised. We have good sound abutments, restorative space is adequate, financial situation is affordable, sound, residual bone is adequate, we can go for any fixed options, but medical condition is compromised. So what it means patient cannot undergo any extensive surgical procedures because of any reason. So in such situations, as our abutments are strong, we can go for precision supported partial dentures or cast partial dentures. These two are really viable options in medically compromised cases. But of course, the proper planning, as I'm not going in depth in the treatment planning of cast partial dentures, hope if I get a chance next time, I'll definitely love to speak on that, because it is again a long story. The planning of cast partial dentures, we need to survey, we need to plan the type of impressions, the abutment selection, the framework selection, the major minor connector, everything. We need to plan it for designing any cast partial dentures or any precision supported removable prosthodontics. So in this situation, as the medical condition is compromised, we can go for a removable or a semi-rigid options for such case. So the next scenario is scenario 4, again, mandibular missing teeth, Kennedy's class 1 bilateral. In this, financial situation is compromised. Rest all other things are bearable. Bone is good, abutments are good, space is adequate, medical conditions are favorable. But it doesn't mean we can put straight away the expensive implants, because financial situation is compromised. So we have to respect the patient's this situation, and accordingly we have to proceed. You can discuss all the options, or if you can give the EMI options, the monthly installment schemes, if you have in your operatory, that is one way. Otherwise, straight away you can go for the cast partials, although it is also not very cheap option. You can temporary phase, you can plan for flexibles, but of course that is it for a temporary phase. And meanwhile, if patient can afford his expenses, you can go for the cast partials or whatever. Need to discuss in detail with the patient. So next scenario will be huge bone loss. Atwood's last classification, huge bone loss. So in this case, patient has huge restorative space here. So how to cope up with that? In this, abutments are periodontally sound, but restorative space is enlarged. Medical conditions are favorable, financial situation is favorable, affordable, but residual bone is also resolved. In such cases, if you somehow place the conventional implants, the crown and the root ratio, the abutment and the implant ratio will be compromised, will be hampered, and at the end, it will not going to survive for long term. So either you need to go for augmentation if patient can afford that. Otherwise, you can go for CPDs with thick base or flexibles for time being, or 3D printed implants. They can work good or work well in such situations. So this is the one situation where you have enlarged restorative space. So that was about the Kennedy's class 1 situations. Now a brief introduction to the Kennedy's class 2 situations. That will be very short. So far we have discussed the scenarios for Kennedy's class 1, that is bilaterally missing. Now Kennedy's class 2, unilaterally missing. So if you have strong abutments, you can straight away go for the precision supported RPDs. You can use RINE 83 attachments. They work very well. Of course, they have some flaws, but of course, if you have nice treatment planning done and abutments, if you have good premolars, you can definitely go for the RINE 83 attachments. Next is if financial constraints are there, again, the same philosophy, need to talk to the patient, need to plan the EMI options or the cast partials or the temporary phase with flexibles. And if it is medically compromised, you cannot go for the surgical procedures for implants or something, then you have to go for a flexible or precision supported RPDs or the cast partial or the metal framework, removable prosthodontics. So this is some situation of Kennedy's class 2. So to summarize, I would like to say that I have made a flow chart of different situations and the treatment options which you can opt for it, and you can apply those decisions in your clinic, and maybe it will be helpful for you. So these are the different clinical situations. This is fixed option, segmental fixed, and removable option. So it depends. The first situation, number of remaining abutments. You should always look for the remaining abutments, whether it is a single missing tooth, whether you have both molars missing or premolars and molars missing. Because in single tooth, you can straight away go for fixed option. Whereas if both molars are missing, you can go for fixed, you can go for segmental as well, you can go for removable as well, depending on the patient situation. But if premolars and molars are missing, then segmental option is not that easy. You have to go for fixed or removable options. One more thing I like to add in segmental fixed prosthodontics or the precision options, you need an adequate space for that. If you have a limited space, they are not successful. You cannot place a precision there. I have discussed here in inadequate restorative space option here. So if it is a unilateral distal extension, all the three options are open for you. If you have a bilateral distal extension, again, all the three options are open for you. In bilateral, we have additional advantage, that is a contra arch or the contralateral stabilization is there. It will be a little better. And the next is if you have an inadequate restorative space, the fixed and the segmental options are little compromised in those situations. So you can go for the removable. But of course, if you can somehow gain the restorative space, if it is because of supraeruption or any other reason, then definitely you can go for the segmental or the fixed option as well. And the last one situation is systemic conditions. So I've talked a lot on this already. If the patient is compromised medically or because of any reason, you cannot go for the extensive sinus lifting procedures or the Zygoma implants or the pterygoid implants or the conventional endosseous implants, you can go for segmental options and removable options. These are the situations like systemic condition, if patient really can afford the procedure and patient want to go for fixed option, but we are helpless. We cannot do that because of the systemic conditions. So here we need a lot of motivation, a lot of counseling is required for the patient to motivate him to the semi-fixed or segmental fixed or removable options. So I can say this is all about my today's presentation. And this is my additional activities. We have a training academy in India where we conduct courses on dental implants, on full mouth rehabilitation, on microscopic endodontics. And he's my partner in that, Dr. Saurabh Banerjee. And we both are directors in this academy. We had many successful sessions already accomplished. And here you can reach me. This is my personal email ID, my Insta account, and my profile account. So thank you. Thanks a lot.
Thank you, Dr. Rahul. Wonderful presentation. I took notes because it has been extremely interesting. Some things I've not.
Can I stop sharing my slide? I can open them easily. Don't mind.
Sorry?
Just a second. Yes.
Yes.
I'm back here.
Okay. I was saying that I listened very carefully because if we want to be real good dentists, that's my humble opinion.
I cannot hear you, sorry.
You can't? Can you hear me now? Can you hear me
You're
now?
not audible, madam. Sorry.
My microphone is open. We have technical issues.
It's
Hold
not mute
on.
from my side. I cannot hear you.
Now you can?
I can
Let
hear
me
you,
see.
Dr.
You can. So it's only
Dr.
Dr.
Rahul,
Rahul?
can you hear me?
Sorry, I cannot hear you again. I'm sorry for that.
Oh, what can we do?
Can some technical team will help in this?
He can
Not
hear me.
audible.
Let me see. I'm going to try to write.
I cannot hear you,
Okay.
ma'am.
Um, I can hear everything, so whoever's listening, hold on just a second as we try to fix this. One second. Okay.
Okay, I
Let's
will
see if
log
we
out
can.
and log in again, ma'am.
Okay. In the meantime, I'll be talking just a little bit in general to our deserving listeners. I do believe that as dentists, we need to have an open mind about everything that Dr. Rahul has discussed today, because I feel a trend into the today's dental school approach to consider only the more advanced options, and so to consider implants, restorations on implants, screwed in and out. Welcome back, Dr.
Good
Rahul.
evening,
Can you
ma'am.
hear
I
me
cannot
now?
hear again.
I don't know why. This is so strange. I have perfect connection. So should we continue? But then you can't hear me to respond what I'm saying. Let's see what we can do. Hold on just 1 second. Unfortunately, this is what happens when you go live. Sometimes there's a... Can you hear me now or no? Hold on. Let's see. Okay, so basically I was just saying, and as soon as Dr. Rahul can hear me, I will ask him his opinion about this. I do believe we need to be trained, and the technicians need to be trained, because that's a very sacred art that's becoming more and more abandoned in the favor of veneers and of only implant-borne prosthesis. And sometimes patient is just not having it for many reasons. So as clinicians, this discussion is super important, because at each step as dentists, we have an opportunity to preserve the prosthetic space for the future rehabilitation of our patient's mouth. So when we extract a tooth, we should be well trained and know how to preserve a ridge. We should be trained in different techniques. The sock and shield technique also is gaining momentum, and at least we should know about these procedures to see which one is more suitable for our patient. So in different steps, we can preserve the prosthetic space when we find supra eruption and we are thinking either of approaching a restorative case or referring. We could see if with our orthodontist or with some skills into the dental general practitioners armamentoire, we could be able to regain that lost space. Let's see if Dr. Rahul is... Do you still hear me or no? Can you hear me? No? No? Okay. No one's answering us. So I think we have to just say goodbye, because if it's not working, we have to just say goodbye, right? I'm going to write a mess. We can hear you. Hold on 1 second. 1 second.
Yeah, can you hear me?
Yeah, I
Can you hear
can.
me?
Yes.
I cannot hear anything of yours.
I know. So
There's no
I feel
voice.
very
I don't know
bad.
what is wrong. I'll try once again. I'll log
Um,
out and log in again. Once again, I'll try.
okay. Okay. All right. So today I feel like the news anchor with the news not coming through. Unfortunately, it was a very interesting presentation. So if anyone has any questions that they would like to submit, please write on the permanent link on global summits, and we'll be more than happy to try and connect. I don't know if Dr. Rahul can hear us. Some friend is suggesting to try connecting from the laptop, and anyone who's following, if you, I finally found a online connection to Facebook, so if you would like to ask some questions or share your point of view, please let us know, and that way we at least try to have our final goodbyes with Dr. Rahul when he manages to get in touch again. And yeah, don't be shy about questions. Let's strive to work better, learn more, and also communicate correctly with our technicians, because some of these conical crowns that I learned in dental school, that tells you how old I am, and I've done some of those were amazing solutions, but of course the hard part was to have a technician capable, because then it becomes an amazing lab work. It needs a lot of skills to be super functioning, and I'm in love with those type of prostheses, even if though they're a little bit outdated, because that's an extra help we could have. Okay, we can send. Can you hear us now, Dr. Rahul? Still nothing. Let's see if we have any questions. No. Questions are missing, so
I cannot hear anything, ma'am. I
yeah.
think we should stop this live thing. We cannot
Yes.
hear this. Yeah.
Right.
If anybody has any questions, they can email me on my personal email ID, of course. I'm really sorry. I don't know what glitch is that. I cannot hear any sound in my system. And really sorry for this.
That's okay. So we thank everyone that joined, and for any questions, please write us on Facebook Live. Thank you.
Okay.
Bye-bye.